Thank you, Madam Chair and committee members. My name is Catherine Wheeler. I'm a board-certified OB GYN. I practiced for 24 years and I performed abortions. I'm asking you to oppose 1279. And here's why. Can you imagine with me being in the middle of doing an abortion procedure? My instruments are in the uterus going for the baby, and suddenly it's as if ripped from my eyes the blinder that kept me from realizing what I was doing. I had no choice but to finish the abortion. I never did another one. I did not speak about this. It was so horrifying for 20 some years until I moved here to Colorado, which was just before Proposition 115. When I realized that the babies that I used to fight for the lives of were now being murdered. I'm sorry to use the M word. I don't know what else to use. I did this until the time of birth. I could no longer be silent. I looked at the research. I saw new research, different than back in 2005 and 2006 and beyond, that the baby actually has the capability to feel pain as early as 12 weeks. These babies felt what I was doing. There has never been consensus that babies don't feel pain before 24 weeks. That was a conjecture. We've heard a lot about safety. Unfortunately, this bill removes safety for women. I love women. That's why I did OBGYN. I care about the woman too. It doesn't talk about the fact that medical abortions cause 4 times the complication rates of first trimester surgical abortion. It doesn't talk about the fact that after the first trimester, these women who get telemedicine abortion may take abortion pills at a time when there's 40% complication rate. It doesn't talk about the fact that at 18 to 21 weeks, the mother's chance of dying is twice that of childbirth. I ask you to oppose the bill. Thank you.
Your time is up. Thank you. Thank you, Madam Chair. This question is for Dr. Wheeler. So, as a former practitioner of this practice of abortion, can you just walk us through, like, what does informed consent look like? What do the procedures look like? What does it look like with respect to health of the mother, and just that picture, if you could paint it more clearly for us?
Thank you, Madam Chair.
Dr. Wheeler.
Thank you, Madam Chair. Thank you, Representative. As far as informed consent, when I was in medical school and just starting practice, we were moving away from paternalistic informed consent when it became very important to tell people all of the details. I will be honest, when it came to talking about abortions, I did not tell the women what happened to the baby. I did not want to make it too hard on them. And I withheld that information. I believe that's a common practice. I had a private practice. I only did abortions for my patients. So informed consent should be all of the information about what the procedure entails, the risks and the benefits, all of the alternatives, their risks and their benefits, and then answering their questions. That is what should be the informed consent process. My understanding from this bill and from what I've seen happening in other legislatures throughout the country is that this would then allow no informed consent because it's considered in some other, it's being presented as a barrier for the women to have all the information. That's a big concern that I have. And I'm sorry, the remainder of your question.
Representative Luck. Thank you, Madam Chair. Just walk us through the whole process of a girl comes in. Now we've understood informed consent. What do the procedures look like? What is the health indicators for health of the mother, that sort of stuff?
Yes, thank you for your question. I did second trimester abortions specifically at the University of Utah and a couple in my private practice for babies with fetal anomalies or severe genetic syndromes. At the University of Utah, we did not at that time do any so-called elective abortions. The last abortion I did was a first trimester so-called elective abortion. The process in the first trimester is like a gynecological D&C, except the uterus is larger and very, very soft. And so it makes it more complicated. It's very difficult to feel the edges of the uterus as you go. I began to do Ds and Cs under ultrasound guidance because one of the most common complications is perforation of the uterus, which can injure the bladder in front, the bowel which lays around it, or the rectum behind it. Sometimes you have to drop in a laparoscope or do an open abdominal surgery to repair injuries. Other complications could be hemorrhage, some of the tissue remaining in, some of the fetal parts remaining in, infection. In the second trimester, after about 14 weeks, that's where the majority of people who do abortions, which is less than 17% of the OB GYNs, starts to get much more complicated because the uterus is now up out of the pelvis. At 20 weeks, it's at the belly button. The uterus becomes softer and it changes position. I don't know how many doctors do that under ultrasound guidance. I would never do it that way without it. At that point, you put in a suction cannula after you've dilated the cervix. You withdraw the fluid that compresses the baby so you can get hold of it. You then put through forceps and start removing arms and legs and the abdomen. I was trained to get the head first. It's very hard to get the head later. It rolls around. So we had something called Sophro forceps, which you grasp the head and you have to make it small enough to come through the cervix. At our hospital, we did not do them after 18 weeks because they were that complicated. All of those were referred to a pregnancy center. I never did any in the second trimester, but when I moved here, I had to look it up. And that procedure involves what Dr. Perel has discussed, that the baby's life is ended now. That can take, what they describe as a lot of movement is very similar to babies with cord accidents. When I read Dr. Hearn's description of what he tells his patients, that is what the patients tell you when their babies have died of a cord accident, that they struggled. And so if the baby has not died by 24 hours, they can re-inject. They then insert something called laminaria, which is sterilized seaweed, into the cervix. From the moisture of the cervix, it gradually expands and may induce labor. The fact that there's now a dead baby in utero will also induce labor. At that point, dead babies from stillbirths are incredibly hard to deliver. There are special instruments to remove the baby in parts if necessary, or forceps. Those are all very complicated procedures with a high risk for perforation of the uterus, also blood clots in the legs and lungs. As I said, mortality rates from abortion are double that of childbirth beginning at 18 to 21 weeks. Does that answer your question?
Representative Neville.
Thank you, Madam Chair. And Dr. Wheeler, you discussed some about when the unborn child will start feeling pain. And forgive me, but it's been 5 years since I had my last child, but I remember hearing the heartbeat and that wonderful sound. And so I remember some of that stuff, but can you kind of walk through the different stages of development that we're talking about? Because this bill has no restrictions on any time of development. So just kind of walk us through that developmental stage for the unborn child.
Dr. Wheeler.
Yes, thank you for that question. Well, about 6 to 7 days after fertilization of the egg, it gets to the uterus, it comes down the fallopian tube, it implants. By 22 days after fertilization, it has a functional heart with actual blood flow going through the body. By 5 weeks, it has 3 parts to its brain. By 6 weeks, it is starting to respond to touch. By 8 weeks, all of its organs are completely developed, and the ones that can, so it's basically so-called knit together by 8 weeks. At that point, what's continuing to happen is the continued growth and development of those organs. One of the last to develop is the lungs, although it is there and developing even at 8 weeks. The brain continues to develop, and the reproductive organs are the ones that continue to develop the most through the remainder of the pregnancy.
Representative Baisley.
Thank you, Madam Chair. Dr. Wheeler, thank you for your powerful testimony. And so I think you could probably help us to understand that argument about the health of the mother or the life of the mother, where, that's, I think, a concern that we all share. The mother obviously has the right to her life as well.
Yes.
But when is that necessary, an abortion to save the life of the mother? Is that frequent? Can you give us an understanding?
Yes, thank you for that question. I never actually saw that where an abortion was required. But we did hear some testimony today about women with life-threatening complications. What I noted from their testimony is that they had babies at viable ages and were able to make those decisions for life. The woman I heard with severe preeclampsia, I believe, said she was either 25 or 26 weeks. And so then what you do, if there's a life-threatening complication after the age of viability, is you deliver a live baby, and it has an option for life, and you take care of the mother. I heard the woman with spontaneous rupture of membranes. And in that situation, we truly are talking, if you're remote from term, pre-viability, and you can't get to the age of viability, that is a very dangerous situation. And usually the health of the mother the true life of the mother is protected. That would be one of the rare circumstances. I saw that once. Counting my residency, 28 years. I saw that once in 28 years, and she chose to continue the pregnancy. I honestly don't recall if we ended up with a live baby, but she ended up, I think, for a few weeks continuing the pregnancy, trying to get to viability. But at 22 weeks and beyond now, there's no need to have a demise of the baby. The fastest delivery, and I've done a lot of these to save a mother's life, is to get the baby out. You just do a C-section, get the baby out. You've got a live baby. The mother's lungs don't have all this pressure from the uterus anymore, and their survival rates are better. And I've seen that with chicken pox. A lot of people don't know, especially pregnant women are vulnerable to that. This woman was on the ventilator with pneumonia and looked like both she and the baby were going to die. We did a C-section. They both survived. And I saw that again with sepsis. And then I had a patient who had a motor vehicle accident on the way to her induction, and we were prepared because she had CPR to just try to deliver a live baby, and unfortunately neither survived.
Thank you.
That exhausts our time of questions for this panel. Thank you.